Moving on, John's going to give us, I think, a very informative talk here about what we probably don't talk about enough, certainly during training, the finances and the business of medicine, particularly ASCs.
Thank you guys for giving me a chance to talk about this topic. My relevant disclosure is that I work at ASC, but I don't own any equity, so kind of sad about that. But ASC spine surgery is very different. It's not just taking the simple cases that you do in hospital and take it out and doing a smaller place. So it's not really the question that you should be asking. It's not like, can this case be done? Really, the right question is, can you do this procedure by you? Can you be efficient and select the right patient? Do you have a proper anesthesia team? Do you have proper protocol to handle any complication that could potentially happen? Don't think with your wallets. You gotta practice the right medicine, choose the right cases. Why this matters now? I think the patients are prefer to be in an ASC setting for a more straightforward DJing cases. There's a lot more predictable scheduling. If I try to do a one-level discectomy in the hospital, they get bumped. There's delays. There's equipment trays that get infected. So there's a lot more variability. The surgeon opportunity, I think there's a lot opportunity to become a lot more efficient. You'll have a lot more say in who to hire, who to fire, and you have a lot greater control of your environment. The payer pressure, I think the payers are increasingly cutting down the professional fees. There's an increase in relation, and opposite to that, there's an increase in facility fees. So there's a lot more financial reason to do these cases in a ASC. But the caveat is that not every patient, a surgeon, or procedure or facility is ready for this. And it really comes down to the four things: the patient factor, procedure factor, surgeon, and facility. I kind of covered the patient. You want to choose the right case. You don't want to do this in a medically really sick patient with a cardiopulmonary comorbidities, largely limited to a smaller BMI and a healthy patient, young patient. The procedures, you want to do the procedures that are very predictable, under 2 hours with less complications. Even if the complications do happen, you know how to handle it. And if there's a catastrophic complication, then you have a chance to transfer that patient out of the ASC to the hospital. As a surgeon, you want to have a reproducible technique. I think Ankit actually mentioned that with the endoscopic procedures now I'm doing at ASC, you don't want to do a endoscopic TLIF as your first case, even though it's possible at ASC. You want to perfect those techniques, get very reproducible time before you transition those cases from the hospital to the ASC. Facility, you want to have a spine-trained staff, like the nursing. They know what to look for the back pain. They know how to handle people complaining of a neck pain and the back pain after surgery. And you have anesthesia that feels comfortable handling any emergencies. So, start conservative. I'll start doing posterior cervical. First started out with the lumbar surgeries, then moved to the cervical, posterior cervical foraminotomies. And then you can start to expand to a more fusion, single level ACDFs, TDRs, and then TLIFs. But you want to start very conservative and choose the right patients. You don't do these big high deformity cases and then expect to do these in the outpatient setting. And I think the reasonable cases are lumbar discectomies, and I think those are probably the bread and butter cases you can get under 2 hours. Central decompression, I think not every central decompression can be straightforward, so be selective. Don't tackle on these pinhole calcify large facet joints that likely will get a dural tear. You're going to hate yourself, so should be selective in those. I think endoscopic also, you want to be facile. You want to have a predictable outcomes. You don't want to be at the early learning curve of your endoscopic journey. You want to be sort of in the middle to late. And then I think the single level fusions in a medically optimized patients, this include TLIF, can be done. The laterals and ALIFs, unless you have a very experienced vascular access and you have a ways to transfer these patients out, those are more facility dependent. I think multi-levels, complex revisions, severe stenosis with a high dural tear risk, and do not do those cases. So this is actually I went to Epic and pulled out my ASC days. This is real cases. April 2nd, about a month ago, I did 4 cases. One was a 4-5 discectomy. The next one was a 5-1 discectomy. The third case was a 4-5 discectomy. I got the CSF leak. And then the last case was a far lateral discectomy. And then the first one was about 73 minutes. Next one was about an hour. The last 2 are under an hour. So this is a real timeline. First patient checks in at 6 a.m. They're in by room by 7:30. And then you're starting the case by 8. So you get the idea that it can be very, very efficient. This is one room, not 2 rooms, and turnovers are about 20 minutes, even in academic settings. So my general rule of thumb is that you want to do 4 cases before 4, 5 cases before 5, 3 cases before 3, and you want to be efficient in moving things along. And how far in practice should be doing this? And I don't think there's a perfect time to say, oh, you got to wait this amount of time in practice before you jump on. I actually think that a very mature practice may be very difficult to transition out of the hospital. Probably the sweet spot is somewhere in the early to mid-career. But really before that, you want to have a reproducible outcomes. You want to select the right cases. And then you want to have a right system in place to handle anything that happens in the ASC. So you have to have a protocol. You have to meet with your anesthesia team. You have to meet with your nursing team, sort of educate the nursing team how to handle the post-op nausea, look for any warning signs. If you're doing an anterior cervical, they know how to handle those airway issues and alert the teams. You want in intraoperative complications like durotomy, you want to make sure they have these sutures necessary to repair it, Tactoseal, Duraseals. And you don't want to just look for those. You want to have those in place before you do the lumbar cases. And the finances, the largest cost is the staffing. And you can really, if you look at it as a healthcare system, the reason that ASC works is because that staffing is a lot thinner compared to the hospital. That's why it's a lot more profitable for you to do the surgery at ASC. And the implant and biologics, you can really control that cost by the surgeon. So, and this is sort of the kind of punch in the nuts. If you look at these are just professional fees and facility fees for the post-cervical fusions and then lumbar TLIF. Facility fees on the left side it's got an upward trajectory, and then the right is the professional fees in comparison. It's got downward trends, and just comparing, the facility fees are increasing with inflation, but professional fees are flat or decreasing in relation to the entire payment system. So. I think when it comes to finances, if you're buying into the ASC, you want to be sure that you have the proper ownership structure, is governed properly. You've paid a fair market value for this. The reason is that you don't want to be in a situation where you're incentivized. The anti-kickback and the Stark laws, you don't want to be on the other end of that. So you want to make sure that you have the proper governance, that you're not getting paid by referring your own patients to your facility and making money. And you want to have that governance. And I think certificate of need and non-con states, I think this is really important if you're thinking about opening the ASC. If you look at that's the map, so it kind of follows the political line, right? I'm actually surprised that California is a non-con state because it's pretty communist. But if you look at all the states, the reds are, you can open the ASC without getting the certificate of the needs, but then the blue states, you need to get that paperwork done, and which serve as a sort of a barrier to entry to open the ASCs. I think the upside is real. I think there's a huge financial upside, but it is an investment. It's not a passive income. You have to run it properly. You have to be compliant with the ownership and then the way you get paid. So I think the final checklist is that your indications have to be disciplined, your cases have to be predictable, outcome have to be predictable, your facility has to have all the components to handle complications, have bailout strategies. And if you're still refining the techniques, if you're still learning the techniques, don't do those cases at ASCs. So I think that's my talk. Thank you.